guess what? If you didn't know it, maybe this will help. If you didn't know it, cardiovascular disease is a leading cause of death and disability in the world. I won't focus too much on these slides because you've heard all about it already and you know it, but it causes about 1/3 of all global deaths, and you can see that that's not distributed equally. And there's hotspots of activity. You can see predominantly the whole of Russia has high rates, and also parts of Central Africa. Now, Australia might do well globally, but we're not exempt from this problem at all. And what I've done here is collapsed the latest data from our Australian statistics. And you can see I've coded the cardiovascular diseases in red and the cancer types in blue. And I do that because we generally have this trade-off, might be amongst ourselves, of the disease wars, and we compare cancer with cardiovascular disease. And then the bottom half of the graph, I've collapsed them all together into all CVD and all cancer causes. But the independent cause of death in Australia is coronary heart disease. And when you break that up for men and women, you can see that it is still number one for both men and women. But overall, cardiovascular disease causes more deaths in women than cancer, but it's the other way around for men. And the reason for these statistics is because our cardiometabolic risk factors remain high. Aside from smoking rates, we've done really, really well at reducing the rates of smoking, or prevalence rates of smoking in Australia. We've cut them down by half, but I don't think we've done particularly well, if not we've done worse, with our other risk factors in this area. And I disagree with Graham. He's not in the room anymore, so I can say something about him. I don't think we've really made significant inroads in addressing cardiovascular risk. There's really been no change over the last 30 years in the prevalence rates of people who have high cholesterol. It looks like it lately with the dip in the latest survey, but I think that that's a statistical flaw. We really haven't done too well also with blood pressure. There's an inverted U-shaped function. We did see it coming down, but it's rebounded back up. And that blue bar there is a study that we did 10 years ago to show, instead of going to taxi ranks, like Karen went to taxi ranks in South Africa, we went to shopping centres in Australia and measured about 13,000 Australians' blood pressures, and we showed that the prevalence rates were pretty high and were pretty spot on and matched what the latest population surveys are showing. And we've done abysmally with obesity. So you might see that there's a slight reduction in the overweight category, but all we've done is put them in an obese category. So we haven't lost weight, we've gained weight. So we're moving in the wrong direction. So that was data from a population perspective, and I'm now going to show you some data similar to what Nigel was talking about from a primary care perspective. And this was touched upon in a report that the Baker produced at the beginning of this year. And one of the reasons that risk factors remain high, it's not all, there's many reasons, I'm just going to talk about this one, is that our risk factors aren't being treated effectively. And this slide here shows that about half of people who are treated for having high blood pressure or having high cholesterol don't meet their treatment targets. And it's a little better, as is shown in this slide, for blood pressure, but I actually think that it's worse than what this slide shows as well. Now, we've done some research with accessing mass data sets from primary care, not the National Prescribing Service data, but another group of data that you can buy from another company. And we've written 3 reports that have looked at blood pressure levels in 500,000 and more, and cholesterol levels and diabetes and blood sugar levels in 500,000 plus patients over 5 to 10 years. And what we found for blood pressure in particular is it's more like about 40% of people, not 32, so it's a bit higher than what the Baker report, but about 40% of people treated in the primary care setting actually have elevated blood pressures. And then when you individualise their treatment targets, so once a person has had a heart attack or a stroke, their target for blood pressure is lower, it's stricter, so it's harder for them to meet it. And when you assess people by their background and medical histories, it goes up to almost 60%, so it's almost double of what has been reported. Now, I just want to show you data from the report that we wrote looking at blood glucose levels in primary care, and this was accepted about 11 o'clock last night. This paper got accepted in Diabetes Research and Clinical Practice. But we showed that average HbA1c levels, which is the glycated hemoglobin levels, which give a longer-term indicator of blood glucose control, that they're higher in treated patients, and there's been little improvement in those levels from a primary care perspective over about the last decade. And on that graph, you can see the top line shows people who are treated with insulin, the middle line shows people who are treated with oral medications, and the bottom line shows diabetic patients who are treated with diet and lifestyle. And irrespective of the treatment that they're on, around 40% of patients had elevated HbA1c levels above that the guideline magical target of 7%. But when you look at the proportion of people meeting that target, according to medication, 15% of people achieve that target of 7% in diet, if they're diet and lifestyle controlled. 47, so about half achieve their targets, 1 in 2 on oral medications, and a whopping 75% are above the target when they're on insulin. We also did something quite different in this paper, and what we wanted to quantify was the amount of time that patients, their HbA1c levels remained above a threshold with ongoing treatment. So just to explain this graph here, that middle line at 7% is our target threshold, and each dot on the graph represents a visit to the doctor. So this graph this is a pictorial representation that anything above the line, so they've gone to their doctor and they are above target, and their doctor knows that they're above target. So we've called it avoidable glycemic burden, because they know that you're above target but may not have done anything about it. So what we did in our paper was looked at the amount of time that patients are allowed to stay above their target, whether they're not treated at all, whether they are on oral medications only, or whether they are on insulin only. And we quantified that the avoidable, so it's important to stipulate that it's avoidable because you've gone to the doctor, you know about it, and your doctor knows about it, but no titration, no up titration of treatment has occurred, or no change in treatment has occurred. So the time that patients were permitted to stay above that 7% line was about 9 months when they were diet and lifestyle controlled, about 16 months for oral medications, and they were above target for on average 27 months when they were treated with insulin. So there are lengthy time periods that they are above their threshold. So as you know, we don't treat risk factors individually. They are additive and they act synergistically to increase disease risk. And I have to acknowledge Andre here. You might have seen his slides yesterday. I've stolen these slides from him because they're so good. You'll see that in a second. So here's a fella who there's some negative behavioural risk factors here: high saturated fat diet, a couple of fags, the couch potato, and a few alcoholic beverages. These all contribute to increased cardiovascular and metabolic risk, and they can cause obesity as well as other conditions such as hypertension, high glucose levels. And they have an effect on the inside, our insides, our arteries, as you all know about it, which is the atherosclerotic disease process that over time develops to increase our cardiovascular and our metabolic disease risk. As I said, this contributes to hypertension, high blood sugar levels, lipid abnormalities, And the clustering of these together is what is termed the metabolic syndrome. And the metabolic syndrome predisposes to type 2 diabetes, and that is a key risk factor, as well as individual risks as part of the metabolic syndrome predisposes to cardiovascular disease. So to sum all of that up, a large proportion of cardiovascular and metabolic diseases are preventable. The behavioural risk factors are modifiable, metabolic risk factors are modifiable, and some other risk factors are also modifiable. But let's move on to some other non-traditional risk factors that Graham was alluding to. And one of them that I want to mention, brought up by Graham, that we have a key interest in is sleep. And I think Simon's going to look like one of these 7 dwarfs in a nappy later when he gets old. So there are clear... It's all right, I'm not in the debate, so I've got my chance now. There are clear associations between sleep problems and all of the metabolic syndrome, diabetes, and cardiovascular disease. And not only sleep disorders, but also sleep duration is independently associated with an increased risk of coronary events. For example, one of the most common sleep disorders, obstructive sleep apnea, which occurs when there is an obstruction to the upper airway that causes breathing cessation, is found to be, or there is a clear association between OSA and hypertension, plus other forms of cardiovascular diseases, coronary heart disease, heart failure, and stroke. It's also been shown that both short and long sleep durations are independently associated with fatal and non-fatal coronary heart disease. Despite their importance and the cardiometabolic disease burden, though, sleep disturbances aren't well detected or managed. So in the centre that I'm the director of at the MacKillop Institute, we have a focus on developing community interventions to improve cardiometabolic health, and we do this via nurse-led models of care. Our key focus is on primary prevention more so than secondary or chronic disease management, and we have a key interest in vulnerable communities, that is the Indigenous community and also people living in regional communities. And our key translational aspirations are to establish the evidence for nurse-led clinics and also to develop new tools and programs to help support people like GPs and nurses to improve patient care. So what we've been doing in this space over the last 4 years or so is we've developed a metabolic syndrome severity score, and that was done together with a postdoc I had, Joshua Wiley. We're also in the midst of our modern trial, and our nurses and our research team are in the audience today. And this trial is called Modern. It's an NHMRC funded trial. We've got about 9 months to go. It's a 2-year follow-up trial to improve metabolic syndrome risk factors in people living in regional communities. And we've got a clinic set up in Colac and Shepparton. There's lots and lots of data collected, lots of elements to it, but we are looking at diet, daytime and nighttime behaviours, including sleep, what preferences, so what choices do people want for the type of healthcare that they receive. So if we can get an idea of what they like, we can tailor management to suit them, because it's more likely going to lead to improved outcomes if it has their approval. We're also conducting health economic analyses. The reason for that is you heard Dr. Di Natale speak in the morning. There's no point us developing a disease management program if it costs the healthcare system more. It has to work as well as be cost effective. And health behaviours that you might have heard Andre speak about yesterday. And the vehicle to achieve that is a health behavioural model where we're using various forms of intervention styles to achieve change. I won't go through the results of this, as I said, because it's ongoing, and I am blinded still to the two groups. but we screened just under 1,000 people. About 850 odd people came in to visit the clinic for a risk assessment. Because we are interested in people who are at risk by virtue of having the metabolic syndrome, about 1/3 of them were eligible and about 2/3 of them weren't. It doesn't mean that they weren't at risk. They might have only had 1 or 2 risk factors, just not the magical 3 or more that made them eligible for the study. And then we randomised about 276. Just briefly, don't worry about reading so much this slide, but look at the colours. Red is worse and green is good. So you can see that there's predominantly, blood pressures were okay, but there's a large degree of obesity and overweight in the people that we screened. Remembering this includes both eligible and ineligible people. Total cholesterol was elevated. Again, I've probably used a pretty strict cutoff at 4.5. And there was some degree of elevated blood glucose levels, indicating that there were people who were in a pre-diabetic phase. I won't focus too much on this because you heard Graham talk about it, but we're also interested in looking at cardiovascular risk in the Indigenous population. As Graham said, the focus of this is to try to identify some new markers of cardiovascular and metabolic disease. He spoke about the results of the echo data. We're interested in also finding new lipid species, and our key focus is on sleep and wake behaviours. The reason for having an interest in the sleep component, and this really is led by Stephanie, who was here. Oh yeah, there you are. Thought you'd gone home. Is Indigenous populations are known to have poorer sleep quality compared to non-Indigenous people. And as Graham said, traditional risk scores tend to underestimate risk in this group. Sleep abnormalities, if they're detected as well as treated early, might help to reduce risk of cardiometabolic disease in this particular group. So using actigraphy, this is just pilot data arising from the same data source that Graham spoke about. Indigenous Australians showed signs of insomnia, that they had a higher average number of awakenings per night. They slept slightly less below the recommended requirement, and they had excessive daytime sleepiness in about 20% of people, which is a lot more than the rate in a normal population. And these nocturnal awakenings might be due to a poor sleeping environment where there's overcrowding, noise, and uncomfortable bedding or sleeping positions. So in conclusion, cardiovascular disease remains our biggest killer, not only in Australia but globally. And cardiovascular and metabolic risk factors, they haven't significantly improved for over 30 years, and in fact they may have worsened. And in the primary care setting, these risk factors aren't being managed successfully, and what we need is earlier and more vigorously intensified management. Sleep disturbances are closely associated with and contribute to the burden of cardiovascular and metabolic diseases. And what I think we need is more research of interventions, possibly sleep intervention studies, in high-risk individuals, with an emphasis also on improving cardiometabolic risk and outcomes. Thank you.